Welcome to Obstetrics and Gynecology Forum. I am your host, Dr. Olabola Olaniyi. Today we shall be discussing another important topic in obstetrics, which we refer to as antepartum hemorrhage. Today we shall be giving the overview of this topic, and subsequently we take all the important parts of the discussion in our subsequent the discussions, because in order to be able to understand and appreciate this topic very well, it will be cumbersome if you take this topic in one session. So today we are giving the overview of antepartum hemorrhage under this outline. What is antepartum hemorrhage? Antepartum, it means that something that happens before delivery. Ante means before, partum is the process of delivery. So antepartum hemorrhage is before delivery. Hemorrhage means bleeding. That means antepartum hemorrhage simply means bleeding that occurs before delivery. Let me point it out here that obstetric hemorrhage, which is bleeding in pregnancy, is the major cause of death among pregnant women. It's responsible for about 25%. That means 1 out of 4 women that die as a result of pregnancy will be due to bleeding in pregnancy, which can occur during the process of pregnancy or after delivery. So this topic is very important because it contributes significantly to the death in our women. So we are going to be taking it in different sessions. And what do you mean by antepartum hemorrhage? Antepartum hemorrhage means that a woman that is pregnant, a normal healthy pregnant, will start noticing bleeding through the vagina, simply put, and this will put a lot of anxiety on the woman. For a woman that has been otherwise normal in pregnancy to start noticing blood coming out through the vagina is really alarming, and is a relatively common condition. Although some of this bleeding may not be severe enough to compromise the life of the woman, but in cases where it's severe enough to compromise the life, especially in about 2 to 3% of cases, that is 2 to 3 out of 100 women who will have this large volume bleeding, it may lead to death or serious complications. And because of the importance of this condition, is a condition that every woman must be aware of. It's a condition that every doctor, every midwife must be confident with, because it is very important we do so. Now, how do we define antepartum hemorrhage? Like I said, antepartum hemorrhage means bleeding in pregnancy, but it's not every bleeding in pregnancy that is antepartum hemorrhage. What is the difference? Bleeding can occur in early pregnancy, which we refer to as usually as abortion process. But the bleeding that we refer to as antepartum hemorrhage are bleedings that occur in late pregnancy. Simply put, antepartum hemorrhage means bleeding in late pregnancy. And when do we refer to pregnancy as being late? Usually from the 24th week of pregnancy. 24th week means about 14 weeks to the end of the pregnancy. Or traditionally, we tend to use 28 weeks, which in this part of the world we refer to 7 months of pregnancy, because of the viability in this part of the world. But presently, we tend to reckon with 24 weeks because of the advancement in the neonatal care, because we know that babies that are born after 24 weeks have reasonable chance of survival. So that means from 24 weeks of pregnancy, from around 6 months of pregnancy, when a woman starts noticing bleeding through the vagina, we refer to such bleeding as antepartum hemorrhage, as against bleeding that occurs before that period, which we may refer to as a process of abortion. So simply put, antepartum hemorrhage means bleeding from 24 weeks of pregnancy. Now, how do we classify this bleeding? Like I said, the ones that are really alarming are the ones that are directly related to the baby. Bleeding that come from the uterus, those ones are more alarming and they are more important to this discussion and to our women. We classify Antepartum hemorrhage, there's obstetric and non-obstetric. Obstetrics means bleeding that come from the uterus, from within the inside of the uterus. And non-obstetric bleeding are bleeding that we call incidental bleedings. They are occurring not because the woman is pregnant. They can also occur if the woman is not pregnant. So such bleeding may not compromise the life of the mother or the baby. And such bleedings are not usually as much as the ones that come from the uterus. So for the benefit of this discussion, we say we have what we call obstetric hemorrhages and what we call non-obstetric hemorrhages. Let's talk about obstetric hemorrhages, which is the real meat of this discussion because of the importance. What are the causes of obstetric hemorrhages? Let's come to this diagram. This is the diagram of the womb. This is the uterus, the baby, and the placenta. This part is the placenta. What happens? What is the role of the placenta? Placenta is the engine room of pregnancy. It's through the placenta that food, blood, nutrients, oxygen gets to the baby from the mother. Now, if you look at this diagram, you can see that from the muzzle of the mother to that side of the placenta, these dotted lines mean that there's a region of flow of blood from the mother to the placenta. All this red dotted line means blood, and the blood flows into the placenta and goes through the umbilical cord to the baby. Now, let me point here that in pregnancy, in every minute, about 700 ml of blood, that's more than a sachet of sachet water, about 700 ml of blood, more than a pint of blood will flow to these parts of the uterus in every minute. That means the volume of blood that gets to the baby is very high. Now, what happens if bleeding occurs through this interface, the interface between the baby and the placenta and the uterus? The bleeding tends to be very heavy, either when the woman is still pregnant before labor or after labor. That means a woman can lose up to 700 ml of blood within a minute if the bleeding is severe. And an average woman has about a gallon of blood in her system. So if she's losing like 700 ml in every minute, we know how long it will take for the woman to bleed to death. So now, when we talk about obstetric bleeding, we look at it, there are three major ones among others. Now, there is something we call abruptio placenta. That's premature separation of the placenta. Normally, what happens is placenta will separate after the delivery of the baby. The placenta will separate from the wall of the uterus and it will come out. But in a situation where separation occurs before labor or before the delivery of the baby, because in this interface, bleeding will now start occurring behind the placenta, and we said the bleeding is so much, so the woman will continue to bleed inside the uterus behind the placenta. Sometimes the bleeding will come out and we will see it outside. The bleeding can be massive with some other attendant complications. We call that one premature separation of the placenta, which is referred to medically as abruptio placentae. Now, the other common type of bleeding is what we call placenta previa. That means a placenta that is not localized where it should be localized. Usually, the placenta is in this part of the womb, but sometimes placenta may be located in this lower part of the womb, covering where the baby is supposed to come out through. So when the placenta is located there, we call it placenta previa. It can be totally here or partially here. So such placentas, when uterus start contracting and the womb is trying to open, bleeding will occur, and the bleeding tends to be very torrential, heavy. So we call that one placenta previa. The other common cause is what we call marginal sinus bleed. Is another cause. That means there is placenta separation around the margin of the placenta. So that one is usually not as serious as the total separation, which is the major separation. Another important cause is what we refer to as DIC, coagulopathy. Some women may, because there are problems in the clotting system, the blood will not clot. What makes an and need ureter to stop bleeding is because there are some agents in the blood that make the blood to clot, to form like a lump and prevent further bleeding. If any condition that makes blood not to clot will cause massive bleeding. There's something that we refer to as circumferred placenta, a situation where there are large surface, the placenta is covering very large surface of the uterus, can also lead to bleeding. And there's something we refer to as fallopian period, because most of the bleeding usually come from the mother, except in some cases where the bleeding is massive and when there's placenta separation. But there's a particular one that bleeding is directly from the baby or from the fetus. We call it vasa previa. That means there are veins that are linked, that come from the placenta into the membrane. This black part is the membrane lining the uterus. If the vein passes through this part, the opening of the uterus, and this vein ruptures, bleeding can come directly from the baby, and that one easily kills the baby. And the good thing is that it's not very common. Such bleedings are not very common. Another important one that may occur is what we call uterine rupture. Due to certain conditions, the uterus may break down or rupture, tear in pregnancy, especially in the uterus that has had a scar, the uterus that has been cut before, either through what we call mammectomy, the removal of fibroids, or maybe a woman that's had surgery before to deliver a baby, which we refer to as cesarean section. So that part that has been cut before may be weaker than the other part. So if labor is not well managed or the patient is not chosen well, that part can break down in labor and can cause bleeding and death. So by and large, those are the common ones, and those common ones are the ones that we are going to be highlighting in our subsequent discussions. Placenta previa, that is when the placenta is not located in the lower part of the uterus. Abruption placenta, which means there's separation of the placenta from the uterus. And uterine rupture, when there is tear in the uterus due to certain. So those important ones will be discussed fully in subsequent discussions. Now, what are the ones that are non-obstetric causes? Like I said, non-obstetric causes may occur even if the woman is not pregnant. So they are just incidentally found in pregnancy. For example, any bleeding that is coming from the vagina, this part in the vagina, any bleeding that is coming locally from the vagina, either from vaginal infection, what we refer to as vaginitis, or due to some tear in the vagina from trauma, we call it vaginal laceration. Usually, vaginal laceration can occur from trauma, either foreign body causing a tear from outside, or even there is something we call coital laceration. So women have tear during sexual intercourse. So such tears may cause bleeding, and that bleeding will not get to the baby. It will not affect the baby. Another important reason is what we call bleeding coming from the cervix. Cervical polyp, as discussed in our last session. When there is a polyp on the vagina, the polyp may bleed, because cervical polyp may bleed. Cervical infection, what we refer to as cervicitis, may cause bleeding. Cervical dysplasia, which is a progenitor to cervical cancer, may cause bleeding. And cervical cancer, a woman that has cervical cancer, the cancer of the entrance to the cervix can bleed. So, and there's something we call cervical inversion or cervical entropion. When some part of the cervix that are supposed to be inside that are exposed to the outside, they may also be friable and bleed. So such local causes are non-life threatening, and they are referred to as non-obstetric hemorrhages. The good thing about such bleeding is that they are also easily managed, except in the case of advanced cervical cancer, which may not be easily managed. But most cases of local bleeding from the vagina and cervix are easily managed, either with antibiotics in case of infection, or in case of laceration and tear with surgical repair. So by and large, those are the common causes of antepartum hemorrhage or bleeding in late pregnancy. Now, what is the principle of management? A woman that is bleeding in pregnancy, what is the principle of management? Let me point here first and foremost that a woman that is bleeding in advanced pregnancy must be managed in a facility where they can handle massive bleeding, large volume of bleeding. That means in a facility where they can carry out surgical procedures, in a facility where they have blood banking facilities, in a facility where they have anesthetists, people that can manage emergency. Number two, such cases must have facility to monitor compromised babies. A baby that may come out needing serious resuscitation. That means the specialists that we refer to as neonatologists, people that manage babies less than 1 month old, should be available, because some of those babies may come out in a very bad state and they may need management, and some of them may come out prematurely and they will need what we refer to as incubator care. So that's number one. That's number two. Another important point is that when a woman is bleeding in advanced pregnancy, such a woman should not have what we call pelvic examination. You must not allow a pelvic examination to be performed on you when you are bleeding, because there is this type what we refer to as placenta previa. When the placenta is located in the lower segment, if you insert your fingers into the vagina, it may provoke further bleeding and massive bleeding. So in such cases, until you are sure that the bleeding is not from a placenta that is low lying, you must not do a pelvic or even rectal examination through that means examination through the vagina or through the anus. So that is very important. That must be at the back of your mind. When you are pregnant, in late pregnancy, and you notice bleeding, first go to a hospital where we have obstetricians, where we have blood bank facility, where we have surgical facility, pediatricians, and some other backup. First. Secondly, do not present to any facilities where they won't be able to manage and they will make a mistake of inserting their fingers into your vagina, because it may worsen your condition. Now, when we have life-threatening bleeding, a woman that comes in with massive bleeding, the woman may come in shock. And how do you know that they are complete? Because before a woman may notice any sign, the woman will have lost about 1.5 liters of blood. So how do you know yourself that I am getting compromised? You may feel thirsty, you may feel faint, you may not be making urine, you may feel irritable, you may just start getting confused, you may not. So when you notice all those ones, you will know that something serious is happening. That because sometimes the blood that is coming out may not be signal, may not be enough to assess what you have lost, especially in the case of abortion where bleeding may occur inside the womb and it may not come out. So when you start noticing those things, please go to a good hospital. Now, when you have life-threatening condition, when you get to the hospital, what do you expect? There's something we call resuscitation. Make sure you are breathing, make sure you have enough blood, make sure if you need drug, they give you drug. That means bleeding means loss of blood. If there's no blood, immediately some fluid will be given to you to replace blood, while efforts are quickly made to get blood. We know blood is life. So we get there, we call it initial resuscitation. That is not the time to start looking for how the baby is. So you need a quick assessment of your own condition to save your own life in such cases. And you may need blood transfusion, and you may need some certain advanced medical care, sometimes intensive care. So when the condition is life threatening, the first thing that your health workers will do is to save your life first. But in cases where the bleeding is not life threatening, a woman is bleeding in pregnancy, you are not seriously compromised, you will be assessed in the hospital. We call it a quick assessment to look at your general state and the state of your baby. So after such assessment, they will now determine with a very quick ultrasound, what we call bedside ultrasound, the state of your baby and the age of the baby. Is the baby matured? Is the baby alive? Now, if there is no bedside ultrasound, from the clinical assessment, from your examination, they examine your general condition, they may now examine your uterus. From the examination of the uterus, they may be able to know the condition of the baby and sometimes the age of the baby. So then you take a step further to carry out certain investigations, like to know the level of blood in your system. Does this woman need blood? You want to say, okay, Like I said, that some condition may make your blood not to clot very well, and that one will further provoke bleeding. They will do a test to see, is this woman's blood still capable of clotting? So they do all those tests. They do, and like I said, they will not do a vaginal examination until an ultrasound has been done to confirm that the placenta is not low lying. Can be vaginal ultrasound, can be translabial ultrasound across the vagina, or an abdominal ultrasound. There are advances now that make it more accurate, what we call Doppler ultrasound and color Doppler, which we actually is very good to diagnose placenta previa that your placenta is low lying. Now, after they have ruled out that placenta is low lying, then a vaginal examination can be done either through speculum or through what we call colposcopy. That's a telescopic procedure to look into the vagina, so that such condition that we refer to as local causes, the non-obstetric causes, may be determined. Maybe if there is any lesion around the surface of the vagina, such lesions will be seen and they can be handled. If there is no lesion, if the placenta is not low lying and there is no lesion in your vagina, then what we are left with, okay, probably there's what we call placenta separation, which may be also suspected also from the examination. So we have done a scan, the placenta is not low lying, there is no local bleeding from your cervix, from your vagina, then a high index of suspicion will now be raised on the possibility of placenta separation. Now, by and large, like I said, if blood needs to be cross-matched, blood will be cross-matched. If you need transfusion, you will be transfused accordingly. So for non-life-threatening condition, by and large, that is what we are going to do. Now, with that, the subsequent management will now depend on what has been found on such evaluation. So the process to now take to manage the bleeding will now depend on, okay, should we allow, if the woman is in labor, should we allow the labor to continue? Or if the woman is not in labor, should we allow the pregnancy to continue? Or is this bleeding or the clinical condition of the woman so bad, or because the baby is so bad that we must quickly go and deliver such women through what we call cesarean section? Your doctors will determine that and manage you accordingly. Now, what are the likely complications? The complications can be, like I said, can be to the baby, because a baby that's lost blood or has been exposed to low oxygen in the womb may come out either as asphyxiated. What they call asphyxiated means that the blood that has been getting to the baby may not be enough. It may cause some damages to the brain and other organs in the baby. Some baby that we call come out as vegetables, we call it cerebral palsy, because damage has occurred to their brains. Some babies may come out dead. So by and large, it means bleeding in pregnancy may have serious damage, because serious damage to the baby, or permanent damage to the baby, or even death. Now, mother, when a woman is bleeding, like I said, the woman can bleed. The bleeding may affect the blood flow to the kidney. We call renal failure can occur, heart failure can occur, the woman can go into shock, the woman the bleeding can lead to death. And aside that, there are other complications, because the risk of surgical intervention is also high because of this condition. So such women too may be exposed to risk of what we call hysterectomy. In some cases, the uterus may be needed to be removed permanently to save the life of the baby. And all the other complications of surgery may also occur. And for the baby too, prematurity is another very important risk, because sometimes when bleeding occurs before the baby is fully matured, the baby just has to come out. So the baby may come out premature with all the complications of prematurity too. So now, in conclusion, we have been able to give an overview of what we call antepartum hemorrhage, meaning bleeding in late pregnancy, which is a subset of what we call obstetric hemorrhage. Like I said, obstetric hemorrhage is the commonest cause of death in pregnant women, either during pregnancy or after delivery, responsible for up to 1/4 of all the cases of death of our pregnant women all over the world. So we have said that this topic is very important, that everything must be done to make sure that our women enjoy the joy of pregnancy and childbirth. Thank you for listening. In our next discussion, we shall be taking this topic one after the other. We are going to be discussing Subsequently, we are going to be discussing placenta previa, we are going to be discussing abruptio placenta, and we are going to be discussing uterine rupture. Please try and watch. If you have any question or comments, you can get back to us. We attend to your questions and comments. Subsequently, thank you and God bless.